This is Cruetzfeldt-Jakob Disease, or CJD. It is a uniformly fatal neurodegenerative disorder caused by exponentially propagating misfolded proteins known as prions. Once a single rogue prion forms, it initiates an exponential cascade. It physically forces adjacent normal proteins to adopt its diseased state, creating a chain reaction that leads to rapid brain cell death. In the 1980s, Dr. Stanley B. Prusiner identified this mechanism, proving proteins themselves could act as infectious agents without any viral or bacterial DNA. CJD manifests through three primary etiologies. Sporadic cases account for 85%. Variant CJD comes from contaminated meat. The remaining 15% are familial. Familial CJD is driven entirely by genetics. It is caused by inherited autosomal dominant mutations in the PRNP gene, located on chromosome 20. PRNP is the specific gene responsible for encoding the body's normal prion proteins. Individuals carrying specific PRNP mutations, such as the E200K variant, are biologically predisposed to this misfolding cascade. The mutation destabilizes the protein structure, causing it to spontaneously misfold later in life. Familial CJD is not an infectious pathogen or an environmental outbreak. It is an endogenous systemic failure programmed into the patient's own DNA. Tracking and eventually eradicating it requires treating it as a persistent genetic baseline. This chart plots variant versus familial CJD incidence. The flat baseline is familial. The massive 2000 spike in variant cases was an environmental crisis, triggered in the UK by consuming beef contaminated with bovine spongiform encephalopathy, a cattle prion disease. The outbreak originated in the agricultural sector, where infected cattle entered the human food supply before the specific pathology of BSE was fully understood. By the 2020s, variant CJD cases dropped to near zero globally. This decline directly resulted from strict agricultural culling policies and comprehensive bans on certain livestock feeds. However, the incidence rate of familial CJD remains locked at roughly 0.15 cases per million people. Because it is dictated by human inheritance, it is completely immune to environmental legislation. Since familial CJD is a steady-state genetic constant, data scientists must build specialized automated surveillance pipelines to map inherited clusters over time. Mapping familial CJD presents an immediate obstacle. Because the disease is exceedingly rare and universally fatal, specific patient pedigrees are heavily obscured from public view. Strict medical privacy laws prevent the public tracking of direct familial relationship networks. Specifically, HIPAA in the United States, GDPR in the United Kingdom, and PIPENA in Canada are national data protection frameworks that heavily penalize the unauthorized release of identifiable health information. To bypass these restrictions, data engineers map genetic clusters using anonymized proxy metrics rather than direct patient names. The required proxy variables are built by passing raw, unstructured patient data through a filter that strips identifying information. The remaining data is then sorted into regional geographic aggregations, like country, state, or province, cross-referenced with age cohorts. The system applies rigid age-gating logic to classify the disease subtype without seeing the patient's history. Data for patients under 40 is routed to a potential variant CJD pathway, while data for patients between 50 and 70 is routed to a sporadic or familial pathway. The universal anchor required to query these disparate international databases is the ICD-10 diagnostic code A81.0. ICD-10 is the 10th revision of the International Statistical Classification of Diseases, a globally standardized system for logging diagnoses. By combining regional geographic aggregates with age-gated filtering on code A81.0, epidemiologists map the shadow of genetic familial CJD clusters, identifying the specific communities where the disease is most prevalent, without ever violating individual patient privacy. Executing this pipeline requires automating data ingestion from three distinct decentralized national surveillance centers. In the United States, tracking relies on the CDC Wonder API.
An API, or Application Programming Interface, is a set of protocols that allows different software systems to communicate and extract data from each other directly. The specific API query parameters isolate the multiple cause of death table, parsing the results exactly by state, year, and age group. The United Kingdom presents a different tracking challenge. The UK National CJD Research and Surveillance Unit does not provide a clean API endpoint for automated extraction. To extract the UK data, researchers utilize a Python-based web scraping methodology. Using software libraries like Beautiful Soup and Pandas, a script parses the HTML document to target the structural elements of a table specifically labeled Cruetzfeldt-Jakob Disease in the UK. The Python script is programmed to explicitly separate the rows containing variant cases from familial cases by indexing the HTML table columns. For Canadian tracking, the methodology shifts to utilizing the open data portal maintained by the Public Health Agency of Canada. Researchers query the Canadian Notifiable Disease Surveillance System API to pull aggregate national CJD mortality statistics into the same standardized format. This automated tri-national pipeline successfully transforms fragmented, heavily restricted public health endpoints into a unified, actionable map of global familial CJD incidents. With the genetic clusters mapped, the focus returns to the molecular level. Because familial CJD is a genetic certainty for those harboring the PRNP mutation, the ultimate goal is prophylactic interception. The pharmacological strategy focuses on targeting normal precursor proteins before the exponential misfolding cascade can even begin. One approach uses monoclonal antibodies, specifically an experimental drug called PRN100. The Y-shaped antibody passes through the blood-brain barrier and binds directly to a normal, healthy protein structure, physically blocking rogue prions from interacting with it. Clinical trial results for PRN100 at University College London proved the antibody safely crossed the blood-brain barrier. However, it failed to yield increased survival times in late-stage symptomatic patients. Researchers have also conducted parallel exploratory screenings of repurposed compounds such as estemazole and pentosolin polysulfate, looking for baseline anti-prion activity. While monoclonal antibodies and repurposed drugs demonstrate proof-of-concept anti-prion activity, their limited efficacy in late-stage symptomatic patients necessitates a radical shift toward targeting the gene itself. Gene silencing via RNA interference, or RNAi, represents the most viable long-term strategy for eradication. RNAi is a cellular process that intercepts and destroys specific genetic messages before they can be used to build proteins. RNA interference works by physically blocking the translation of the PRNP mRNA transcript. mRNA, or messenger RNA, is the molecule that carries the DNA's instructions to the cellular machinery. By intercepting and dissolving this critical transcript, the RNA interference process stops the body from producing the mutated prion protein entirely. Current laboratory data shows that RNAi interventions successfully slow disease progression and extend survival in mouse models. RNA interference is uniquely suited for familial CJD because the genetic presence of the mutation is known prior to the onset of the physical disease. These experimental gene therapies carry a critical dependency. They require identifying asymptomatic carriers long before irreversible neurodegeneration begins. This is where the data engineering pipeline meets clinical application. By identifying regional hotspots, the surveillance system serves as a tactical map for clinical outreach and targeted genetic counseling. The total eradication of familial CJD relies on this integrated life cycle, utilizing Python-driven epidemiological scraping to locate regional genetic clusters, directing focused screening programs to identify asymptomatic carriers. Once identified through these localized efforts, patients can be enrolled in preventative RNA interference trials before the fatal PRNP cascade is ever triggered.